this meeting will be made available as soon as possible after this meeting has concluded. We welcome the use of the Welsh language at meetings, but I've had no request for people speaking Welsh today, and therefore the meeting will be conducted in English only. Please, can members refrain from using the chat function and instead use the raise hand icon to indicate when you want to speak. Can I remind members that as per statutory guidance made under Section 4 of the Local Government Wales Measure 2011 and our formally adopted hybrid meeting policy, any member attending meeting remotely must be able to be seen and heard by members and officers who are attending the meeting, as well as by the members of the public who are viewing the meeting. So can I ask you all, please, to use your cameras for the duration of the meeting? And can I remember you to ask you to keep your microphones muted when you're not talking? And please do not disturb any discussions until you've notified of your intention to speak and you have been invited to do so. We now move on to our agenda. Jade, do we have any apologies, please?
Yep, thanks, Chair. We have apologies from Councillor Seaborn.
Thank you. Do we have any declarations of interest?
This is a non-prejudicial declaration of interest. We have T. Glassie Dorlan is in my ward, and we have quite a lot.
I think you mentioned that yesterday. Councillor Evans?
Yeah, that's why I put my hand up. Yeah, exactly the same.
Okay. Right, shall we move on to agenda item 3, the minutes of the meeting of the 14th of September. Members are reminded that these are the minutes of the meeting where we scrutinise the work we carry out in support of social enterprise. Could you please state whether you have anything to raise in relation to the minutes, and if not, I'll take them as agreed. We all agreed? Okay. We go on to item 4, which is our action sheet. Bex, can you run through our action sheet, please?
Thank you, Chair. So, members, you'll see there are 4 actions on the action sheet. The first one was with regards to the recommendations from the last meeting and the responses to those you have all now received. There are 3 other actions that are still outstanding responses, but I am awaiting that information and it is expected any time, so I will get that over to you as soon as I receive it. Thank you.
Okay. You happy? Okay. We'll move on to agenda item 5, which is integrated reablement. Before we commence our discussions, I would like to welcome Councillor Dave Daniels, our Executive Member for Adult Services and Housing, Dave Leach, our Strategic Director of Adult and Communities, Sarah Paxton, who is the Head of Adult Services, and Louise Perkin, who is here to observe the meeting. I'd also like to welcome online Alexis Williams, the Director Manager of Torvine Primary Care and Community Services.
So, members, if I can just come in quickly, we are expecting Alexis to join online, but she may have to join late.
Okay, thank you. I now hand you over to Dave Leach and Councillor Daniels to give us a brief overview and introduction to the report before we commence our questioning.
Thank you, Chair, and thank you to the committee for allowing us to bring this one forward today. This is a really important piece of work that I think has been in the pipeline for some time. The report that members have received relates to our integrated reablement approach that we're putting forward. This really does build on one of those cornerstones in the county plan. So the county plan very much emphasises the role of early intervention and prevention across all our services, not just services in adult social care, but all of our services that support the residents of Torvine. And we need to make sure that the systems are in place to be able to deliver that early intervention and prevention activity in a way that makes it sustainable, so that we don't end up having multiple parts of different services that are defined as early intervention and prevention, but are neither intervening early nor preventing flow coming through further into the system. So what you've got presented in front of you today is an approach that looks at that entire flow through the reablement system and how that relates to some initial thinking around the front door for adult social care, which I know members will be scrutinising at a later date as well. There are significant pressures on the horizon in terms of why we're looking at this. Members will be well aware from media coverage, from previous reports, from other discussions that you may be having around some of those changes to demographics and complexity. Put simply, we're seeing more people coming into the system and we're seeing more complexity So we know that we need to do something differently to be able to sustain those outcomes. And that's the key within this report. You'll see, and I'm sure we'll discuss those design principles, of which there are many, in terms of how that service has been designed. But that overarching view from us is that we're intervening early to improve the outcomes for individuals in Torfaen. That's the driver here in terms of making sure that we have an effective system. So we're trying to make sure, in fact we will make sure, that we don't lose the benefits of those what matters conversations, those conversations that allow an individual really to define what matters to them in terms of the provision of their support going forward, while still being able to implement a preventative approach around that. The approach we currently have, and again I'm sure we'll go into this in detail, is reablement activity that cuts across multiple services. What we're talking about here is bringing a lot of that together in a more coordinated and managed system so that we have a reablement service as opposed to reablement activity spread across the board. So that's what you're presented with today. And the question that we'd be really keen to discuss with members overall is, are you comfortable that this new service will promote independence and positive risk and social inclusion throughout that system, with that overarching aim that we're supporting residents to regain and maintain independence for as long as possible in their own homes, which has been a policy driver for some time. Thank you, Chair.
Before I ask Councillor Daniels to come in, I'd like to welcome Alexis Williams to the meeting and ask if she'd want to make any comment before we start our questioning.
No, thank you for the welcome, Chair. I'm Alexis Williams. I'm the Directorate Manager for Torfaen for an Iron Bevan Health Board. I'm happy to support any of the questions if I can from a health perspective, but I've got no comment to make at the moment.
Thank you.
Thanks, Chair. I mean, in terms of details, there's not much I can build on what Dave Leach has already said. You know, the rationale for an increased focus on early intervention prevention is a solid one. I mean, reading through the report, there are various different research which indicate that, you know, it's an essential thing. And you can see from the demographic changes that, you know, where we're headed, you know, in health and social care. So an increased emphasis, which is what this is, on early intervention prevention is an absolute necessity. Financially, there's never a good time to do it, but you know, it feels like the right time now. It feels like, you know, locally our finances are pretty, you know, members have heard in council that finances we're managing reasonably well. So it feels like a good time to try and. It's a phrase I did speak it with Dave about it. It's a phrase that's been ruined, quite honestly, by another politician. But fix the roof whilst the sun is shining. That is the phrase I'd use for this particular piece of work, because this is exactly what it is. It's just a shame it's been ruined by another politician of another party in the past. But yeah, so I'm super enthusiastic about it because I'm a big advocate for early intervention prevention, because it's just such an obvious thing to do. So there's not, in terms of detail, there's not a lot I can add. That might be teased out through questioning, if I'm honest. So just thank you for inviting us today to present the report.
Thank you, Dave. We had a scrutiny pre-agenda meeting yesterday, and we've got a series of questions to bring before you all. So we'll take it section by section. The current system of reablement. I'll invite Councillor David Williams to ask the first question, please.
Thank you, Chair. Can you hear me okay, everyone? Yeah, just checking. Obviously, this is on the current system, and you've highlighted that any changes within CRT are important for ensuring alignment across health and social care and not impacting positively or negatively on TCPC's budget. So it was really just a background question in terms of the CRT budget seems quite high in proportion to the others. So I was just trying to understand, is this staffing and non-staffing cost? And you've made reference to there being a Section 33 agreement, but it's trying to understand that a little better if possible.
Yes, CRT and our frailty is much bigger than integrated reablement, so the budget is obviously much bigger. It includes emergency care at home, which is the part of the frailty system that is focusing in on re-abling people in their own homes, very often following a hospital stay. But in addition to that, CRT has things like rapid medical, rapid nursing, a whole other service that wraps around people. So yes, that budget does reflect that. CRT, emergency care at home part of CRT, is of course part of Torvine Council's domiciliary care service. So it sits, although it sits there within the Section 33 agreement in frailty, it is also part of our regulated domiciliary care service. And as you'll see through this report, our in-house domiciliary care service has 3 branches really. So you've got emergency care at home, very focused on sort of up to 8 days when somebody's left hospital, making sure that they are re-abled and get as much gain from that support as they can. Then we have Tŷ Glas y Dorlan, which is, as many of you know, our short stay, again with a re-ablement focus, and people can go there and have the benefit of a very intensive, actually, re-ablement, because it's staffed with therapies as well as care staff. And then it's our intake service that sits out at T&D and provides longer-term re-ablement, up to 6 weeks in people's own homes. So those 3 branches comprise Torvine Council's internal domiciliary care service. And what we're trying to do here, and what we will do here, is rather than see them as 3 separate parts of a service, bring them in and integrate them across the whole system to be one integrated re-ablement team. So they're all working together with that very strong focus with our RAs and re-ablement assistants, with our practice coordinators, and supported by the therapists, the occupational therapists, physiotherapists, so that we can really focus those efforts with people, because people tell us, citizens tell us that you know, that actually they don't want care and support, thank you very much, they really want to be independent. So if we can intervene early and enable them to either regain or maintain skills, that has to be the right way forward. I think I've answered your question.
Yes, that's fine. Thank you.
I don't know whether Alexis wants to say anything about CRT.
Yeah, I think, you know, from a CRT perspective, our priority is going to be ensuring that the links are still within the team around bringing the capacity together of this resource. But again, you know, just sort of supportive, very supportive of how we increase the capacity within this resource across the borough, because it will support things like our pathways of care for hospital discharges, for prevention of hospital admissions, if we've got that sort of clarity around the capacity within the community.
That's fine. We're next on to question 2, which comes from Councillor Lucy Williams.
Thanks very much, Chair. So this is in relation to the heading performance on the report, 3.7.5, just to try and understand those statements a little bit more. So specifically it was saying that in September 23 there were, it gives the number of people receiving re-ablement, and that there were five people waiting for the re-ablement service. So it's to try and understand, that's the number, but is there also sort of information about how long those waits are, which I guess is an important thing. So that was that question.
That data is our monthly census checkpoint data that we send into Welsh Government. But when it comes to re-ablement, Welsh Government only asks us around our performance, around the emergency care at home CRT aspect of that. So it doesn't ask for the whole of the re-ablement activity. And we think that we're not able then to show what difference we're making in a really meaningful way. So by integrating the system and having one re-ablement system, we will be going back to Welsh Government and saying, actually, what you're measuring is only a tiny part of what we do.
Do you mind if I answer?
No,
I find that's really helpful, because reading the report, I found it surprising that the data was only taken from emergency care at home, which isn't strictly a reablement service. And so I was going back to this 3.7.5, I wonder if you might be able to expand a little bit, but I think you've partly answered, where it says, looking at the intake of T-glacidolin, their focus to date has not been on reablement specifically, just trying to understand what that meant, because I thought T-glacidolin was entirely about reablement.
No, I think you're absolutely right. And in terms of T-glacidolin's role, that is its role, but it's not exclusively on reablement. So there's respite provision, there is extra care facilities within there, and there's the links that we do to help manage winter pressures and other pressures coming through the system as well. So I think that the point that I was looking to make is we've got to be careful that we don't conflate a building with the services that are offered from within that building. And that's the point that we're trying to get across in that rather clumsily phrased sentence there. One thing I did just want to come back on as well, in terms of your question around how long are people waiting in the system rather than just the numbers, as part of this, and I think Sarah picked this up, we're asked to provide certain data to Welsh Government, but that doesn't mean that's the only data that we need to collect going forward. So that's the sort of data that we'll be exploring going forward.
Thank you, David. Anybody else want to come in on that? Okay. And that's question 3. And David, do you want to come back in, please?
Yeah, thank you, Chair. Don't worry, I'm not going to be the only one asking questions. This was just in relation to 382 in the report, because the statement is that the data suggests the complexity of care is being provided by the services increasing. So it was really trying to understand, has there been some analysis behind this to identify any potential trends behind that need for higher care so that we can better align the preventative services? It's a bit more about how you might be able to use that data to help target, I guess.
Yeah, we really do, and we must interrogate our data in this regard. What on the surface it appears to show us is that we're not growing necessarily the number of people who need care and support, but what is happening is the number of hours that individuals are requiring is increasing. That shows us that we have a high level of complexity in the system. But that's towards the end of somebody's journey. Actually, what we're trying to do through an integrated reablement system is really get in there early and prevent some of this complexity occurring, not just from providing sort of reablement services, but opportunities to look at where somebody might currently have 2 carers supporting them on a call. We've got what we call better care or single-handed care occupational therapists. So we'll be pulling them in more to look at, actually, is there a way of supporting this person that doesn't need 2 carers? Because actually having 2 people in your home delivering care is really intrusive. People don't actually want it or like it. So if there's a piece of equipment, and all the time there are new pieces of equipment coming onto the market that would enable somebody to be more independent, for example, they, with a piece of equipment, turn themselves in bed. Actually, really good examples of that. And people tell us where that's in use, that it's preferable. So it's things like that. The earlier you intervene with people, the more positive outcomes you achieve. It's right. But even where people's needs are increasing, we need to be sure by reabling and constantly looking at this that we're not over-providing to people either. And it's something in the service area we call creep. We put in a package of care. I can see Councillor Williams nodding. We put in a package of care, perhaps 2 calls, and over time, 15 minutes by 15 minutes, that sort of creeps up. And it's really important that we are aware of that. We're working with our external providers who provide longer-term care where that appears to be happening, to support them as well. And our integrated reablement service will be able to be mobilised to do that, to walk along and work alongside our independent providers when they're asking for increases of care, to just be sure that that is the right outcome for the individual. But we do know, as the demographic shows, we do have an ageing population, and we do know that if we don't intervene early, people's needs are going to just increase and increase.
Does anyone else want to make any comment? But we move on. Okay. Lucy, you've got the. Steve, do you want to come in your next question, please?
Am I all right? Yeah. My question is on 3.83, and it's a cost of democratic change. I mean, looking at it, with the formula funding for this and grant funding, how are we going to cope with the extra demand if the funding is not ring-fenced?
I think it's a really good question. The challenge that we're presenting here is what happens if we don't intervene, if we don't change the system in the way that it's set up now. What we're proposing before members here is the rationale and the reasons for changing the system. Because if we don't, those costs of demographic change are based on that complexity and on the additional numbers that we're projecting into the current system. So if we don't successfully manage to intervene earlier, potentially looking at reducing the size of those packages that people need because the reablement has proven effective, then we're not going to be able to bring those costs down. What we're looking to try and do is manage this in a way that keeps those pressures as low as possible, so that instead of seeing a potential £5.5 million increase coming into the system, we're keeping that as flat as possible. There will always come a time where those demographic trends catch up and we still start to see it increasing again. But what we're trying to do is reduce the gradient of that curve, if you like, where people are coming in. So that's exactly the rationale and the reason for us intervening, is to try and make sure that that pressure doesn't materialise.
Okay, Steve, do you want to come back in?
Yeah, all I wanted to know if we had some sort of contingency in case, grant funding was immediately taken away. So, yeah, that's great. Thanks for that. Anyway, Dave.
I think Dave wants to come back in.
Sorry, Councillor Evans, I'd misunderstood that. In terms of the specific grants, so the way that the social care system is funded is a mix of funding. So it has funding that comes in from RSG, it has some specific grant, and there's fees and charges as part of the mix as well. So in terms of those specific grants, there are some that are aligned to the reablement service, but it's not a majority of the funding that supports reablement. Reablement does receive that core funding, and that we're not intending to change here. I'm sure we'll go on to a discussion around the funding mix and how we believe we can deliver this in a very efficient way further on through the scrutiny session. But we're not proposing to do that by increasing grant funding sources or anything else. So we're not increasing the risk that we're putting more grant funding in, then if that's taken away, we're exposed.
Okay, Steve. We'll now go on to our next question, which does come from Lucy.
Thanks very much, Chair. So this roughly relates to 3.8.4, but it's a fairly broad question with a couple of bits. So it's trying to understand a little bit more clearly how the current forms of assessment are going to change in this integrated model. Then who will these changes have the most impact on? And how do you see, so it's a slightly multiple question, sorry. So who will those changes have the most impact on? And how would you see the triage system working in practice? Back to you, Sarah.
Dave has already mentioned the link between the adult services front door, and I know that we are bringing a paper to you in January, I believe, on that. So there is a link there. But some of you will remember, we redesigned adult services in response to the Social Services and Wellbeing Act back in 2015. And that's when we went to a patch-based, community-based model. And that is still fit for purpose. However, when we did that at the time, what we had an ambition to do, and what this hopefully will allow us to do, is to ensure that rather than anybody going straight to long-term care provision, that we have the ability to offer reablement as our first offer. So anybody coming into the system will be offered integrated reablement. So a reablement assistant, practice coordinator will do that assessment with the person. What are their outcomes? What is it they wish to achieve? And then a reablement programme, service plan, a programme will be designed with the individual that enables them and supports them to achieve those outcomes. And that will be monitored pretty much on a sort of daily, weekly basis as our care workers, our enablement support workers, are delivering that programme alongside the person. And once somebody's regained their independence or achieved those outcomes, then actually we won't continue reabling. It will be fine, that's great. And we're hoping that that will mean the vast majority of people will then be able, will not require anything, or if they do require something, it'll be that sort of what we like to call the 50p worth of support, the minimum amount of support to keep them living well at home. And then we will look to broker that in our independent, with our independent providers. So that's how this new system will work. So our first offer, our offer will be actually an opportunity for people to be enabled or re-abled, ideally in their own homes, but if not home, as you've often heard us say, why not T Glassadorlan? To come into T Glassadorlan and have that there. So a much more streamlined system from wherever that person enters our system. And as we know, people come from lots of different places. I'm not sure, have I answered all of that question, Councillor Williams? I think there were several parts to it.
Does anybody else want to come in before we move on? Okay. Our next question, question 6, comes from Councillor Clarkson.
Thank you, Chair. Yeah, this is sort of building on Councillor Williams's question a little bit. With this change and with Aneurin and Bevan University Health Board Fast Track being involved as well, it seems that the triage at the front end is going to be crucial to the correct pathways being followed. So just asking for a little bit more information on how this is going to be prepared for, training across relevant teams and the healthcare staff, and how the effectiveness is going to be monitored to ensure that we get consistency at the front door when we bring this in.
If I can pick that one up, Chair. So, no, it's a really good question, and I would imagine that Alexis may want to comment in a minute on some of those health board links through that as well, because that really is key around how we integrate that triage system, not only the back-end support that we're providing through reablement, but that front door provision too. I'm reluctant and cautious about going into too much detail around the front door at the minute, because I am conscious we're going to be bringing that back into members. But the question still is, has some real importance for this paper in terms of some of those performance measures. So the key there for us is how do we make sure in this model where we're saying we need flow all the way through that system, how do we make sure that actually the right people are receiving reablement support after that initial assessment, and of those, the right numbers are progressing through to full independence, the right numbers are progressing into that 50p support as Sarah's described, and the right numbers before that are actually progressing directly back out into the community with a package of community support, which will be a big focus for what we'll talk about at the front door conversation. So what we're developing alongside the report that you've got here today and the one you'll see shortly for the front door is a suite of, I'm calling them performance measures. They're not in the traditional sense performance measures for individuals to say, are you or are you not performing? And we certainly don't want to cause concern or amongst the teams that that's the case. When I say performance, I mean performance of the system. Is the system progressing the right numbers of people through into each of those different pathways? And that's really important, because that's what Sarah, that's what myself, that's what the group managers will need to monitor to make sure that system effectiveness is going on. Then we can start to build the other points that you've rightly raised, Councillor Clarkson, which is around, okay, what are the training needs then? If the system isn't performing in the way that we anticipate, Is it because there's an issue to do with training? Is it because there's an issue to do with flow? Is it because there's an issue to do with capacity? Is it because there's an issue to do with the fundamentals of the model? So we're going to need to run the model for, I would say, at least 12 months before we have that stress testing of where the pressures lie within that system. And when we start to talk around some of the cost implications of the model later on, that's been factored into our assumptions, that we do have some of that flexibility and capacity to be able to test that system as we go through it. So hopefully that picks up on the question.
Alexis, do you want to come in, please?
Yeah, I'm happy to come in there as well around the training for some of the health staff as well. So one of our key pathways for referral is our hospital discharge pathway. And one of the things that we are actively encouraging as a health board is we have early what matters conversations on the wards with patients, so that we can identify what type of needs they may have and refer on to appropriate agencies. Now, one of the things that we are very keen to do is ensure that people are not necessarily signposted into statutory services, and that they are able to go home with the support that they need, but that doesn't necessarily need to be care. So there is an identification of a training programme that's required with our hospital-based staff to ensure that they are able to pick up those early conversations. And again, we will work with Sarah and Dave to look at what does that mean in terms of the pathways coming into social care? How can we help educate our staff in order to ensure that we're not wasting people's time with inappropriate referrals? And, for me, it's all about getting people to the right place at the right time so they get the right support, and we free up the capacity in our system as a consequence of doing that. So hopefully that answers the question from our end.
Thank you, Alexi. Does anyone have any comment to make? Linda?
No, just that pretty much answers the question, and it'll be good to see going forward how that develops, and hear more about it possibly in future seminars. Thank you very much. That was very helpful.
Thanks, Linda. I've got the next question, and it's regarding 3.8.5, the workforce. There are currently 19.5 FTE vacancies across the 3 re-enablement services. Whilst the Council continues to deliver recruitment campaigns, filling some roles remains challenging. So will the proposed model have an impact on the pressure experienced due to the number of vacancies?
There's been a plan, if you like, to hold some of those vacancies, because you'll probably be aware that currently in our internal dom care service we have something called annualised hours. So carers working 25 hours on an annualised basis. What we've recognised for some time is that's no longer fit for purpose, and it's really impacting our ability to recruit staff. So we're about to go out to a big staff consultation starting next week after, to talk to staff about that. But it's our opportunity to change annualised hours, and we think that will help. It's a problem, staff tell us, because actually it does neither one thing or the other. It's too many hours for people to be able to be entitled to working tax credits, but it's not enough hours for people, to have a sole income. So we really do need to take the opportunity to consult with staff. We are consulting, obviously, with the trade unions around being able to do that. But to be able to change, we've needed to hold vacancies so that we can use that vacancy to change the hours that people may work. And we're hoping, we're reasonably confident that if we can make some of these changes, that actually that will improve our ability to recruit people into that home care sector within the council. So there was an intention there for us to do that. That said, you'll be perfectly aware it is still a very difficult and challenging place to recruit care staff, particularly, sadly to say, at this time of year. But, we try, and we continue to try all sorts of different ways of making care and care work valued, valuable and attractive to people, because it is.
Dave, do you want to come in, please?
Just very briefly, in terms of the new system now going forward, vacancies like Sarah said, some have been held back. So there is an opportunity there to realign now vacancies to the model, and some of the savings that you see in the way that we're describing it, they don't all come from reductions in third-party spend. Some do come from a genuine realignment between vacancies where we no longer feel that they're the right roles for the system and the new system. So we will be looking to remove excess vacancies, but it's really important that we don't take everything out in terms of vacancies from the new system when we talk about managing the flow through the system. When, in answer to Councillor Clarkson's question, I talk about us having to test this for at least a 12-month period. We need that ability to still flex. So when we start to talk about the finances, I'm sure a little bit later on in the report, you'll see that what we haven't done is just gone and said that the simplest thing to do here to be able to make this as efficient as possible is to strip out all the vacancies, because that would leave us too exposed. So some vacancies within the system aren't a bad thing, particularly as we have that conversation around annualised hours. It gives us the flex to manage the system in a way that we need to. What we've got to be careful of is excess vacancies and struggling to recruit to roles.
Dave, do you want to come in on anything? I'm sure you'll keep us updated on this. We've got a different format now, so we've come to the end of the first section of our questioning. Scrutiny question 1. Do members agree with the rationale for the new service? So do you want to have a brief, anyone comment to make, or do you want to leave it until the end of the meeting? David?
Yeah, I think the rationale has been set out very well. And I think, the principles, we're going off the principles in a moment, I know, but I think you've cogently pointed out the sort of the opportunities, but also perhaps some of the necessity in terms of pressures that may come if we don't make the change. So I think that's been clearly set out, just sort of to start off, as it were.
Anyone else want to come in, Lucy?
I would certainly be happy to say that I would agree with the rationale. Also adding that I think it's important that we understand that this is the beginning of a process, that it will need to run for at least a year to see whether blockages or any changes need to do. And I would think that that would be part of a recommendation that very clearly we're going to be supporting you in seeing how this pans out once it's operational.
Councillor Clarkson, please.
Yes, thank you, Chair. Just to sort of mirror and agree with those previous two comments, what's been said very much mirrors what we spoke about yesterday at the pre-group meeting. This is the beginning of an ongoing process. It's something we'd be keen to follow through as it develops. The assessment and data is going to be key to evaluating how this is going. So, yeah, the need for the development of the new service is very clear.
See, I endorse everything. As I said, it's a new model and we really have to keep updated and supporting you in any way we can as a committee. We go on to our next section, which is called Service Design Principles. And the first question again on this section comes from David Williams.
Thank you, Chair. Just to say that I think the design principles will make a lot of sense. It was really just on the community-focused one, number 2. Changes in service provision must strengthen the delivery re-enablement in the community. Just whether there's the opportunity to mention the fact of working in partnerships and with voluntary agencies in the community. It's implicit, I think, but I just sort of, as part of the principle, it's the collective approach, which is very much the sort of county plan type way of working. So it's a consideration, no more than that.
Yeah, it's a really good point. So when we're talking around community, or when I put this sentence in the context of community, what we were looking at is making sure that there is a professional delivery of activity within people's own homes, if not within someone's own home in T Glass and Dorland, but very much keeping that focus on people's own homes. The ability of the third sector to get involved and support within re-ablement is an area that we haven't thoroughly explored, and one that I think there is real merit in us taking away and looking at. Now, we need to be careful we don't add complexity in the system through additional commissioning, we need to make sure that it's very much aligned to that community-focused approach of encouraging people to become resilient and independent rather than become reliant on third sector provision. But with those caveats, that's certainly something I'd be happy to take away.
David, do you want to come back?
Perhaps if I can just clarify slightly, I think this was also looking at those sort of things that exist within the community, so that, you know, things like lunch clubs or, you know, meeting groups, men's sheds. It's a sort of, so that, if you like, you've helped people to get that support within the community. That was what I was thinking through that. I think that's fairly clear, so thank you.
Want to go?
I feel like I can finally jump in because everything's been so technical. Yeah, no, I absolutely agree with what you've said, Dave. I mean, I think there's a lot of, I think it's understated the value of community-based support. I think there are a lot of lunch clubs, and like you mentioned, and a lot of groups for people of all kind of demographics to go to that are just under the radar, but they play a massive role in maintaining people's well-being, which I think, and mental health, which I think is absolutely crucial towards maintaining physical and mental well-being. So absolutely, I agree.
David, do you want to come in?
Yes, I think what you're describing is why we always describe it as promoting independence, positive risk-taking, and the key here is social inclusion. We know that people who are isolated, actually their outcomes and their need for care and support increases. And so actually our communities, however you define them, are really key in being able to deliver that.
Thank you, Sarah. Does anyone else want to come in on that point? I've got the next question, and it's prevention is paramount. Are we confident that a proposed service design will increase both the number of reablement packages offered and the positive outcomes?
Simply, yes, because our first offer will be a reablement offer, whereas now that isn't necessarily always our first offer. So yes, as people approach our front door, if they need to go on into, there's a suggestion of care and support, then the offer will be a reablement offer, so an assessment of their potential, the outcomes they wish to achieve, and we'll work with people and their families, their family carers, to be able to deliver that wherever possible. And so it will be a much more intense focus.
Thank you. Anybody else want to come in? Dave?
Yeah, I mean, it's not an exact science. When you're dealing with people, it's not an exact science. There's so many different factors that come into play. But I think the kind of the principle and the logic of earlier intervention and prevention, I think, is a solid one. I think you can say that if we get in there earlier with somebody with all sorts of living conditions, and we help them manage them more effectively and more independently, that will have better outcomes. So I think it's a really frustrating thing if you're talking like in terms of quantitative data, but I think the logic is absolutely solid. So I think we would expect to see those numbers increase and improve outcomes for people.
Thank you both for your response. I think our next question which was from Councillor Clarkson, has been answered, but I'll ask Linda if she wants to come in and make any comment. Linda?
Yes, please, just briefly, because we have touched on some of it. It's about performance focused, and any changes in service provision needing to be accompanied by clear indicators to track numbers and outcomes at each stage of the process. So just what are we using at this point, at this very early stage, to make sure that we're sort of on track, just because of the huge importance of it, really.
Measures are really important, and part of this programme of work is to identify what measures in a new system we need to be looking at. The team lead in this new system will be absolutely required to focus on the performance, and as Dave Leach has said, it's the performance of the system. How well is our system performing? What is the data telling us about the system? Are there themes? Are there blockages? And if there are blockages, what are they? And how do we intervene in the system to remove those blockages. We will work very closely with our colleagues in primaries and communities, because a lot of referrals in will be coming from hospitals and from primary care. So really looking at that, talking to Alexis and her colleagues about any themes or blockages. I'm sure it will come up when every month we look at our pathways of care delays, and there'll be a focus there, and Torvine provides an action plan to say how we're going to manage blockages. So all of those things will sort of start to tie up, I think. But you're absolutely right, Councillor Clarkson. It is really important that we understand the system. So running it for that first year will give us a real opportunity to say, have we got the measures right? Are we looking at and the right things? And if we're not, then we will put in additional measures so that we know what's happening. And of course, to an extent, we have a baseline on what we're doing now, how many people are coming through, what care we're brokering. So we will be able to compare a new system with reablement in the old system as well.
Thank you, Sarah.
Yeah, if I could just say...
Alexis, do you want to come in?
Right, fine.
Okay. Alexis, do you want to come in before Councillor Carr makes a supplementary question, please? Come back. Linda, do you want to come back in?
Yeah, just that gave that extra bit of information that I was looking for, really, about those monthly meetings and how it's going to be assessed in this first year. That's the sort of reassurance we were looking for. Thank you very much for that.
Thank you, Linda. Alexis, do you want to come in, please?
Sorry, I had to knock my camera off 2 seconds then. Yeah, sort of supportive of what everything Sarah has mentioned around the performance information and, how we work together on an integrated basis to ensure that we're understanding the information set and making amendments or, tweaking things as we're going along and learning from the process. I think the other thing is as well, aside from the quantitative data, it's important to have the patient story or the service user story in that, and understanding how it feels for those going through the process and the changes, so that they are getting the maximised opportunities for themselves as well. So I think there will be some of that gathered as part of the review as well.
Thank you, Alexis. We're now coming on to question 11 from Councillor Steve Evans.
Thank you, Chair. Mine's on customer focus. Any changes in the service procedures must result in a simpler process for the customer. How will we seek customer feedback to ensure our new model is customer focused and delivering the intended outcomes?
I think Alexis very helpfully touched on that, but yes, absolutely. We voice and control is really important in our system. It's a fundamental principle of social services and wellbeing, and we will of course be working with and alongside people, asking them, how has this been for you? We will know whether people have achieved the outcomes that they've identified for themselves. And if they haven't, we'll definitely want to understand better. Why is that? Is that because something changed in their world during this process? Is it that the system isn't delivering in the right way for them? Changing our front door, I'm not going to go into too much detail, as we've already said, you'll be hearing about that, will also help with this, because the front door will, in effect, triage people who don't need integrated reablement. It's not the right offer for them, so they won't be going there. We will be finding them the right place in the system to get the support that they need. I'm hoping that's answered your question.
Do you want to come back in, Steve, or are you happy with the response?
No, I'm happy with that. I'm happy, yeah.
Okay. Anybody else?
Yeah, I just wanted to add that qualitative data is usually something people don't particularly like, but in this particular instance, it's the very definition of success for us, really, because essentially we need people to feel more resilient, need them to feel more independent at the end of this. So absolutely monitoring their journey from start to finish is going to be a key part in determining how we're succeeding in this, really. So it's a good question.
Linda, do you want to come in with your next question, please?
Yes, please. Thank you, Chair. It's around regulatory compliance, really. And it states in the report, any changes in service provision must be compliant with relevant legislation whilst promoting positive risk-taking and being open-minded around resource allocation. So this seems to be an area where there may be some deviance between the expectation of the customer and the service about what do we mean by positive risk-taking, and the resource allocation, and what are the boundaries between those two aspects? How are we going to be putting this across to the customer at the end of the day, and the family members possibly, around how that's managed?
Oh, there's a lot in that question. I'm just processing.
Sorry.
No, that's fine. As I said at the beginning of the meeting, yes, integrated reablement is part of our domiciliary care service. So yes, absolutely, a regulated service by Care Inspectorate Wales. And that won't change. What will change is our statement of purpose. So before we go live with the new system, I, as the responsible individual for our Torvines regulated service, will be drafting and sharing with our inspectors our new statement of purpose in relation to our domiciliary care service. You won't be surprised when I'm already having conversations with our inspector about the direction of travel. I'm not anticipating that there will be any difficulties with what we're proposing to do, because it will still come under a domiciliary care service. In terms of your question about positive risk-taking and how individuals will respond to that, we don't tend to talk with individuals and their families using the words positive risk-taking. It tends to be very much a system term rather than something people would say to you themselves. But actually, it's about letting people live the life they choose the way they want to choose it. And that's very much our vision and how we do that, and how we challenge in the system where people, where professionals usually and families can become really quite risk averse. They want to wrap people up in cotton wool, and you can understand why. But actually it's about having really good quality conversations, what matters conversations, both with individuals and their families, to try and actually explain why enabling somebody to maintain their independence is absolutely the right thing to do from, very much from a human rights perspective. It's the right thing to do. But at the same time, always balancing rights and risks. But just taking that very individual, person-centred approach to that. And that is absolutely, all of our staff are trained to have really good quality conversations. Those what matters conversations. And sometimes what matters to an individual is different to what matters to their family carer. So you're having two conversations, and you're trying to support in the middle, really, so that it is understood from a lot of different perspectives and lenses. But it is really key to be able to have those conversations to enable a system like this to work. And where we find perhaps other professionals are more risk averse than perhaps we are, to in a very positive way challenge back and say, actually, that won't enable this person to achieve the outcomes that they are looking for. And often it's a question about, so whose risk is it?
Yeah.
Okay, Linda, are you satisfied?
Yeah, that was exactly the sort of issue that I wanted to raise. It's about, again, training for staff and conversations with family and all involved. And with that, the person who is the client being right at the very centre of it. Yeah, very reassuring. Thanks.
On that question, I neglected to call Councillor Watkins in, so she wants to make some question.
Thank you, Chair. Can I just take you back to the previous question about customer focus? And I completely agree it's very important and we need to hear the customer's voice. Are you able to tell us more specifically when and at what stages you'll get that voice? Will it be part of an assessment plan? You know, will these questions be there at set points so that we know when that's going to be gathered?
Our current process, our integrated assessment, information advice assistant integrated assessment process is very focused on hearing customer voice, because the question really is what matters to you. And if you approach it like that, you will hear that voice. We obviously, we have the ability to use advocacy services. So if people, for whatever reason, don't feel that their voice is being heard, we can use independent advocacy to support them in that journey. We always review our complaints and our compliments. So if we're not getting things right, or if we have got something right, I regularly meet with our complaints officer every month to review all of that. And that tells us an awful lot often about not just an individual's experience, but it can tell us wider things about how the system is operated. So we will always do that. So really from the very start of somebody's journey, that first contact, all the way through to the outcome, we are working alongside, listening to that person's experience, both of the direct support that they're receiving, but also, that wider system as well. So it is absolutely key. And we use that then to reflect on, do we need to do things differently? Is there something about the way we're operating that really isn't delivering? It might be delivering outcomes, but is it doing it in the right way? Is somebody getting a positive experience from that? So we are really interested in our current system as well as in our new system. And it'll be even more important in our new system because it's new, because we're doing something in a different way. And so for people who may have had experience of the current or what will be the old system, it will be really useful and interesting to know what their experience is. So we will most definitely make sure that we take that into account.
Okay, thank you.
Okay, Jane?
Yes, thank you, Chair.
That takes us to the end of our second question. And our scrutiny question 2. Do members agree with the service design principles? David?
Yes, Chair. I think they've been well laid out, and I think the responses that have been given to our questions have given us a greater reassurance of the principles that have been taken ahead. So I would be very happy to endorse that. And hopefully, officers will have taken account of some of our comments, but I think it's been well expressed.
Lucy, anyone else? Are we talking agreement?
Yeah, I agree with David's comment, Janet.
I think there's unanimous support for that. Okay.
Sorry, members, can I just come in quickly? So in terms of your point, Councillor Williams, about officers taken on board, so just to clarify, I didn't know if you wanted to specifically put forward, obviously based on the caveats around not wanting to add complexity, as Dave set out, specifically about that community focus one, and the thought perhaps given to more community involvement.
That would be a suggestion. I think I felt like that was taken on board, but obviously confirmation of that would be helpful.
Our next question comes from Councillor Steve Evans, and it's the proposed service models.
Yeah, thank you, Chair. Sorry it's a bit long, this one. If someone is unable to return to their own home, but would benefit from a programme of reablement, then the patch team will apply. If not home, why not T-Glass Dolan protocol? So the second part of this question is, based on current outcomes and future projections, are we confident T-Glass Dolan would have sufficient capacity to facilitate this protocol?
Put simply on this one, yes, although we need to continue to keep the model under review. And the reason that I can say that with that level of confidence is that we are, through this process, trying to separate out this context that T-Glass Dolan as a service is the only thing that takes place within T-Glass Dolan as a building. So by integrating reablement, we're actually bringing more services together and getting them thinking in a re-ablement focused way. And many of them already do, but increasing that focus on re-ablement rather than taking it away. So T Glassadorlan as a building will actually have a much bigger workforce to be able to call on to support activity. Now, that's not to say that it will always be at the same level as things are in T Glassadorlan. We're very mindful that things will need to change in T Glassadorlan. Some of the focus that we've already started to implement around trying to work more closely with community infrastructure around some of those community activities will be making that more forcefully implemented in terms of this model. So there will be changes in the operating practices for TGD, but that resourcing of TGD will, like I say, be able to draw on the resources across the entirety of that re-ablement system. And we're able to do that because we're seeing it as a whole system in a way that does allow us to remove some of those vacancies from within the T Glassadorlan part of the model. So it's not a reduction in T Glassadorlan, therefore a reduction in re-ablement. It's a growth in re-ablement, which also enables us to remove some vacancies from T Glassadorlan.
Okay, Steve?
Yeah, no, thank you for that response. That was excellent, Steve. Thank you.
Okay.
Yeah, I mean, so Dave's covered off the kind of the capacity and ability to provide in that particular respect. I mean, I'm going to say what I've said all along about T Glassadorlan, and I'm a big champion of it, and I think we're incredibly lucky that we've got it for this particular change that we're making, because it's, for members who remember, I mean, I'm too young, but convalescent care is essentially the model, and it provides that which other areas don't necessarily have. And so we're in a unique position to be making these sorts of changes. So in terms of adding that extra opportunity for providing a better outcome for people, it's excellent. When it's not suitable for somebody to go home, they've got somewhere equally suitable to go to, which will hopefully re-able them back to a position where they can live safely in their own homes and get back on their feet in an individual way. So it's an opportunity for me just to reiterate how lucky we are to have this facility in Torfaen.
I've got the next question, and it's 4.2.1. Re-ablement support will not be provided beyond 6 weeks. What will happen after 6 weeks should a need still be present?
If there is still need present, the really positive thing about working in this way in a new system will be that if somebody still does have a need for care and support, we will then go to brokerage to broker that in the care market. But we will have confidence and assurance that we will only be needing the right amount of care and support, because we will have re-abled somebody. We will know now that, it might be 1 call a day, it might be 2 calls a day, but we'll know that's right. So that in and of itself will be very helpful. And so the people who continue to need care and support will flow out of our integrated re-ablement system into the dom care system, the external dom care system. But where they and us will receive gains is that will be the right amount of care and support for that individual. And if that changes over time, we will be asking our re-ablement assistants to go back out alongside the care provider to just check out what is happening, and are there different or other ways of delivering care or support, or in fact, actually, is it the right time now to increase somebody's care and support?
Just to point out, I mean, I think the table in 3.8.4 probably demonstrates exactly the approach that we take to this sort of situation. The various different pathways and the various different grades. So just to highlight that particular point, really, is that in a nutshell shows the process that we'd go through with an individual like that.
Did anyone else want to? Okay. We move on to our next question, which comes from Linda, please.
Thank you, Chair. I think we pretty much covered some of this for this stage in the new service. I'm sure we'll have the opportunity in January when we do the scrutiny then with the front door to look at it further. So I think this question's been answered at this point in time.
Totally agree. Thanks, Linda. We'll move on to Councillor Jane Watkins' question, please.
Thank you, Chair. In 4.2.3, looking at Pathway A, there's a model there. How aligned is that model with the demographic of Torfaen?
Yeah, it's a really good question, because models like this have been developed across the whole of the UK. So different areas will have very, very different demographics. They'll have very, very different needs. What we've done and what we've tried to present in the rest of the table is the numbers that we're anticipating coming into the system, which is partly a direct translation of that model, but partly also an understanding of what's hit the system already in our current model. So that was the purpose for including that middle column within the table. So you can see there what the model suggests we should be able to achieve if we track national trends, what we're currently achieving, and I think we've talked through some of the reasons why that's different, not just demographically, but also in terms of how some of the data is collected, and then what will happen if we apply the model in its purest form. That first 12 months will allow us to realise, are we able to apply the model in its purest form, or given where we are currently, do we need to gradually get to that point where the model can be implemented in its purest form? So we're making some assumptions here that we can, but that's why we need that 12 months to really see what it means demographically for Torfaen. We could make a lot more assumptions around Torfaen's demographics, and there's a lot of complexity we could build into that, but I still think we'd be asking members to give us that time to consider the model in practice. And that's why we've not done that. That's why we've not broken down demographic categories, etc. in this, because I think we'd still be saying it's just a different model. We still need to test those assumptions. Is that clear?
Yes, it is. Thank you.
Anyone else have any comments or want to come in? Okay, we'll move on to question 17 from David.
I'm quite happy this has been covered already, actually, yeah.
Well, we'll go back to Linda for the next question, please.
Yes, thank you, Chair. I don't know whether you're going to be able to answer this question, but the last few years have taught us much, and I'm just wondering, are we looking at building in, or is it possible to build in any surge capacity into the modelling, and sort of how we can plan for it to be future-proof should we have another unexpected event which would mean a surge in demand?
Ideally, yes. Our own services, whatever the system looks like, have always been the backstop, actually. So if the wider system can't support, then our own in-house services, take up that strain, really. We're hoping, and we'll test this out, that the key is flow through the system. So actually, we will be paying really careful attention to how people flow through the system, because we can't afford for the system to get blocked. When people are able to reach their full potential, we need to move them on to their next point of either community support or longer term care. So we will have to keep that really carefully under review. We do have, as you will know, that's not in scope for this project, a dementia service and a sort of more complex internal domiciliary care service, and we will be looking alongside this how we develop that and whether we need to move capacity. I'm not going to say increase capacity, move capacity that we have in some parts of the system into that sort of longer term to give us that bit of surge capacity, that bit of buffer if the system isn't flowing as well as it needs to be. We work really closely with our health board colleagues around flow out of hospital, because if our systems get log jammed, blocked up, then obviously that has a really big impact on bed capacity within health boards. But actually the key to that, and Alexis won't be surprised to hear me say that, is actually prevention, early intervention, and for people not needing to go into hospital who don't need to be there. So it's about getting not just our system, but the whole health, social care, community system working together to be able to deliver that.
Thank you. Alexis, do you want to come in, please?
Yeah, I completely agree with Sarah. You know, flow is critical in terms of the whole system approach between health and social care, and having resilience within the system and capacity to be able to flex when we have surge pressures is an absolute advantage. And I think this, you know, the outline in the proposal demonstrates how it will be supportive of that process. But you know, absolutely critical that when either a long-term need is identified, people move, you know, onto the right service provision out of reablement, or if they no longer have needs at their service ends. So yeah, you know, in complete agreement with what Sarah has said, that it's a whole system approach.
Thank you. Linda, I think you've got the next question as well.
All right, bear with me a second. Yeah, it's looking at 4.2.5, and it states in the report, as a result of the changes to the service, it is anticipated that changes will result in a saving of £1 million from adult social care budget. Could we have just a little more detail on how this will be achieved without affecting service delivery?
Absolutely. Members will obviously be mindful that I can't go into too much detail for anything that would relate to any consultations. But the important thing here is that there's a mix of areas that we're looking at. So we've already talked about those design principles, and that we want to create a system that's as efficient and as effective as possible. We've also talked about vacancies and about removing some vacancies from the system whilst leaving enough in place to be able to maintain that surge capacity and that flow through the system if we need to. And we've talked around the impact that this can have if we're able to intervene earlier. So if we're able to prevent activity coming in, then our third-party costs, our costs in the domiciliary care market, our costs in the care home and nursing market will decrease as well. So the savings are a combination of things from changes that we're looking at internally through to vacancies, and there are removals of vacancies as we've talked through, and some substantial ones at that. But importantly, reductions in that third-party spend. That is where the real benefit of this system should kick in, and that's why the performance management is so critical to us there. So we've done, as you can imagine, extensive modelling around that to make sure that we've got the assurance ourselves that the model that we're putting forward we feel is realistic to be able to achieve savings at that level. And members will also be aware then that as a result of that, this is part of the Apollo programme that's contributing towards those savings corporately.
Thank you, David. Linda, do you want to come back in, or are you okay?
No, that answers the question. Thanks.
Okay. Thank you.
I think that's become fairly evident as well, to be honest, as with the contributions made from Alexis and others. I don't know if you'd like me, Chair, to pick up the next two questions together. Okay. This was about T-Glasadorlan, and it's 427. So both elements really. To reflect the new emphasis of T-Glasadorlan as a base for community reablement, the new integrated reablement services will be based in their entirety from T-Glasadorlan. You've set this out and you've also expressed in terms of service. Will this create any issues in terms of location and impact on those receiving reablement services, i.e. away from family? I guess that's sort of, you've answered some of it, but it's trying to understand, is this going to create some issues?
I think from clarity, what we're intending is, because we're going to bring those three arms of our dawn care reablement service together, we're going to base them in T-Glasadorlan, but they will outreach from there, and rather than, as you could read that, as if everybody's going into T-Glasadorlan, we will move our base, which is now T-D, to T-Glasadorlan, so all the reablement service activity will go out from there, and I think that will give us real benefits. it will bring all the different roles that currently sit in reablement together. So there may be some economies to be made there. And actually, I think it will provide, as a new way of working, really good support for staff, frontline staff, and as well as managers within that system to really understand and work together to achieve the outcomes that we know we need to achieve. So I'm anticipating that by bringing them all together in TGLAS, the therapists will be there as well. So you've got that real connectivity. There's nothing better than being able to walk across a room or walk up a corridor and say, can you help me with this? And I think that will enable us to do that.
If I could lead into the next question as well. I think that's helpful, and I think, you know, it was implicit from everything you've been saying up to now, but obviously the way it's written sometimes you're checking. In terms of that sustainability and flexibility of service delivery, has there been thought given to another potential site and utilising other facilities in terms of that outreach, some of the engagement, if you like, with some of those other services, buildings, etc.? I suppose we're being mindful here that is trying to reduce the need for people to travel, that services go to them, but actually that there are buildings that they can be met at. I suppose it's the simplest way I can put that.
Yeah, it's a really good point. We've got a delicate balancing act here, because by bringing services together, we also need to create a new culture and camaraderie between those services. So we do need people to be able to mingle, meet, discuss cases, etc., together as individual teams. So I certainly would still advocate for having a single base. That doesn't mean to say, though, that people aren't able to use other premises that are available to the council if they've got potentially rounds or activity in another part of the borough as well to reduce mileage. So we've got broad facilities across the whole of the borough. There's no reason people aren't able to go there. But if we were to look at, say, team meetings or that type of activity, we'd want to try and bring people together in and around that TGLAS Adorlan space.
If I can perhaps just confirm, we were looking, I think, more in the impact of service users. You can see the value for the staff, but the fact that service users wouldn't necessarily be asked to sort of travel or their carers, and therefore the need for if you like, planning so that provision. Yes, it could be in people's own homes quite often, but in terms of some of the activities and assessments, that you are open to using other premises, because we're mindful that this is in the south and there's less resource in the north, potentially.
Yeah, I absolutely understand that. The focus is very much on activity out and about in the community for that. So yes, we are not talking here, just for absolute clarity, of a model where everyone from across the borough is drawn into TGD for parts of their assessment process. That would be done in the community, if not in their own homes, then in a suitable facility nearby.
That is helpful.
Thank you, Dave. It was a question that I raised as well yesterday, because some of the residents in the north of the borough have difficulties coming down, and they can, and if they have gone into TGLAS, they sometimes feel a bit isolated. So if the opportunity was to do something north of the borough, not just necessarily in Glenavon, but I say north of the borough, it would be most helpful. Okay, do you reckon? Our next question comes from Jane.
Thank you, Chair. Have we spoken to any other authorities that have moved into this model of delivery and learned best practice from them, or found out if there are any particular challenges that they faced so we can avoid them?
Yes, we have. I think you'll be surprised to know that. Alexis, before she was in this role, was at RCT, so she's put us in touch with reablement in RCT. We've looked at that. We've been up to Blaenau Gwent and looked at that. And then we've done more sort of, internet paper searches about research and what other models are in. So yes, it is something that at the very beginning of looking at this, we've had a really good look at. There will always be differences. It's not possible, nor is it wise, just to lift a model from another area and kind of develop it on your own. You have to think about it, take the things that you think might work, tweak them. But yes, absolutely, we've done all of those things in order to come up with the proposal that's in front of you. And we'll continue to do that. It's not a once and we've done it and you know, it needs to be iterative. We need to always be hopefully ahead of that curve as things change so that we can change with them.
No, that's very good to hear. Thank you.
Anybody else?
Dave? Just to add that, I mean, you know, the model might, we've looked at models elsewhere, but I think I need to name check the team that basically built this up from the ground upwards, because I think, you know, a hell of a lot of hard work has gone into tailoring this to Torvine. So I think whilst we've looked elsewhere, this has been very much built from the beginning, from scratch, on the basis of what we need here in Torvine. So, and a hell of a lot of hard work's gone into it from our the team behind it, and there's too many to name check really, but you know, hopefully name checking that team will be enough.
When you move on now to question 24 from David, please.
Yes, I think you've largely covered this, which was actually the plan to promote this new model and ensure that all the teams are familiar with it across health and social care. I think it's perhaps your opportunity to say a little bit about how that's going and how you intend to take that forward. And obviously that's a little bit for Alexis as well.
From the very, very beginning, we have in our management team, which we call heads up meetings, we've had a series of workshops. We've actually decided to go from the very big picture. We did Marmot, we did the county plan, we did our service development plan, and we challenged ourselves. Are we, as a service area in adult services, designed to deliver all of those wellbeing objectives? And actually what it told us was we needed to make some changes. That was the way, and I was the phrase I use, we've got the teams on the bus with us. Not everybody, we're a big division, so not everybody can be involved in the planning and all of the workshops. But certainly, I mean, Louise is here and she's the team manager for the East team in adult mental health, and I think I hope you'll agree with me that the teams have been involved. They know where we're trying to get to. If you want to say anything. Yeah, I think the teams are quite excited really at some changes and opportunities. I think often something that is missing for us as practitioners on the ground is that reassuring evidence for families. You know, rightly or wrongly, it's often families that are more difficult to work with than the individuals we're supporting. And that evidence actually goes a very long way in reassuring people that their loved ones are able to manage without assistance and support. It can be really helpful for us. And
does anyone else want to come in?
I was just going to pick up to say that obviously there are staffing implications and changes within this new model. So there will be, we've worked with our HR colleagues, there will be a formal consultation with those staff that may be affected by this new model. And that is about to happen. And as you would expect, we will support our staff through those changes. Change is always difficult. It's difficult for all of us, but actually this change will, I'm confident, deliver much better outcomes for people, and that's what we're here to do.
Okay, we've come to that end of that section. So we need to consult, are members comfortable with the proposed service model and the projection on which it is based? Yes.
I think well, I would say generally yes. I would suggest that a couple of recommendations would be around the fact that, from a scrutiny point of view, clearly T-Glacidolin is really key in this, and it would be good to have a specific update at a certain point. Obviously, we know this is ongoing. If that kind of focus on reablement is working, and if there are any, and what particular blockages there are if it isn't. And I would suggest another recommendation could be, because another key factor is staffing and training of staff, both across the health board and the local authority, so that their roles are working and they feel supported. So I think it would be, I think we would find it helpful, and maybe you would find it helpful, that we had that scrutiny role on looking at those areas of staffing, not just recruitment, but staffing, training, and that they feel that their role is fit for purpose, if that makes sense.
Yeah. If I can come in there quickly, member. Yeah. So obviously in terms of the first recommendation around updates, obviously that's within your gift as a committee to ask for that, and you can revisit that when it comes to vision in next year, and that might be something that you choose to take on the year after. With regards to the staffing and training, do you have a specific recommendation, other than just receiving an update on that? Did you have a specific recommendation that you wanted to put to officers and the exec member on that?
I think perhaps I think it may need to, after the end of the meeting, then we have our final recommendations.
No, I'm just thinking that probably, you know, given the elements of change and how this is going forward, it would probably be quite useful to have a member seminar at some point, probably, you know, 2-3 months in from this, so that you can actually outline that, because there will be some queries that come up potentially, particularly as Louise has pointed out, families, etc. So I think because of the scale of change, it would be helpful to have an update built in.
David, do you want to come in?
Yeah, if I can, just quickly on that, because I certainly see the sense in both of those recommendations. In terms of staffing, just to be clear, one of the things that we need to be really mindful of is that we will be looking to build up those staff profiles now. That will need some time to bed in. So I think for us, an update in relation to how those staffing models are being implemented is something that we could certainly do through seminars and through scrutiny activity. Bringing something in around the staffing model would be more challenging, because that falls under that paid service territory. So just to be clear, that's it.
I think also what would be very helpful in terms of some of that reporting back is a couple of the stories, you know, case studies of stories of what has happened, because that will give the user's voice in this as well, which is hopefully important, as you've outlined.
If you please know, we're on to our last section of questioning. And that's question 26, which comes from Councillor Clarkson.
Thank you, Chair. Again, I think we've covered this with the clarification on the sort of continual assessment that's going on, which would identify any emerging risks, blockages, and that sort of thing. So thanks to the officers for already having answered this question.
David?
Yes, my question was going to be that recruitment could be a risk. I think you've answered a lot of that, but I think in terms of the monitoring of going forward, it is a risk that needs to be monitored.
And I've got the final question. What are the next steps forward in this transition period?
Today was a very important one, so I think that's a very big next step for us. And then I think the next one, and the one that is timetabled next, will be that consultation with staff. And sitting around that, so those are staff that will be directly affected by the change, either because their base of work will change, or, you know, those sorts of things. But I think then to communicate this wider, so the comms around it, communicating with our partners. Obviously, we're already engaged with the Health Board through Alexis, our Integrated Service Board, you know, taking a paper to them to say that that once we finalise the model, this is what we're going to do, and then really make those linkages between integrated reablement and our front door, because it's absolutely key. It's the very beginning of that flow. And at the other end, the flow out, really keeping a focus on is the system flowing, and understanding when it does and when it doesn't, and what that's about. So there is still a lot more to do, but as Louise has said, broadly everybody's very excited about this. You know, people recognise, our staff recognise that it's one of the things that we aspire to, that we're hopefully now going to be able to deliver.
We've come to the end of our questioning, but I'm going to ask Dave Leach Dave Daniels and Alexis if they would make any summaries before we go into our meeting recommendations. So, anything to Dave?
Very little to add, to be honest, just to thank members for the thorough scrutiny that we've had on this. There's a lot of content in this paper. It seems sometimes like changing one part of the system is straightforward, but when you consider the implications on flow, members will see the impact that this can have on a whole health and social care system, so it's really important that we get this right. We're really excited as a leadership team in taking this forward. We're really keen now to start that engagement with staff, which is why today was so important to us, to hear your views before we do so. And we're really looking forward to getting this model up and running quickly. If members are comfortable with the model, and depending on where we go next off the back of your recommendations, we're quite keen now to get this up and running as quickly as we possibly can. Because we want this system in place ready for the new financial year, not only as part of the support for meeting those financial implications, but also because we genuinely believe that the sooner we can implement this, the sooner we can start to improve outcomes for people. And that would be my big request of members, is that we continue to look at this through the lens of the outcomes that we're trying to achieve, both for individuals and for the council as a corporate entity. And really thank members for the questions we've had based around that today.
Thank you, David. You've been very quiet.
Well, thank you for starters for having me. It's much appreciated. It's a good opportunity. And just an observation, really, as one of the frontline team leads in social care. I think we're always trying to promote with our staff that message of always changing, people's needs evolve, change, re-ablement, independence is key. But actually, promoting a service like this reinforces our message across the whole of the organisation. So it sort of actually brings staff on board with the thinking, because they can actually see that, you know, our support doesn't stay stagnant, people's needs do change, and when they change, we'll be able to commission care and support around them appropriately.
Thank you for coming, and I hope we've made you feel at ease. Thank you. Come in, please.
Sorry, was that for me then?
Yes, please.
Yeah, I just wanted to echo what Dave and Louise have said. Really, you know, I think this is an exciting opportunity for us to sort of repurpose the flow through the system from an integrated health and social care approach. I know obviously this touches upon the social care elements of it, but I think it's a fantastic opportunity, and, you know, really critical to how we want to move forward and set that agenda going forward with all of our teams, to say, you know, we have to focus on that preventative agenda and ensure that people maximise their independence levels as much as possible, because that's where we get our really resilient communities from. So just in support of what Dave and Louise have said.
Thank you. Well, that's come to the end of our meeting. We thank you all for your attendance and hope we haven't put you under too much pressure with all our questioning. You're now free to go if you want to, have your cup of coffee. Will we consider our recommendations and make them to you? Thank you. We're just going to have a few minutes quiet because a couple of our councillors need to be excused for a few minutes. So please don't leave. Okay.
Is it an age thing or what?
No.
And this, yeah, if I can just remind you, obviously the meeting is still being webcast, but if you can just bear with us for 2 minutes, we take a quick, short break and then we'll be straight back with you. Thank you. points throughout the meeting and the discussions. The first one was, do members accept the rationale for the new service, which you all agreed that you did, with the understanding that it's the beginning of a new process, and stress that the assessment data was key. Question 2, again, then that was with regards to the design principles, and you commented that you felt they were well laid out principles, but there was the commentary around the community involvement and the community focus in terms of consideration being given to awareness of voluntary organisations. And then question 3 was, are members comfortable with the proposed service model? The consensus was yes, with the addition of recommending that you would like a seminar once the model is sort of embedded, and then again for your own selves as a note, consider this perhaps at visioning next year in terms of a review of the first year of working of this new model. Then finally, there was then provided any further recommendations. So members, I didn't pick up any others unless you'd like to put
Jane
some
wants to come in.
Councillor Watkins.
Thank you. I just wondered, I wasn't sure where it would come in that, but can we specify case studies?
Yes.
Oh, yes. Yeah, because I thought that was a very valid point.
Sorry, yes, I did note that down, but I didn't say that. So yes, I'll make sure that's included in there. Thank you.
Dave.
Sorry, we need to consider the front door report coming here and the opportunity to bring this together as a whole model. So I think there's a... So I suppose there aren't many recommendations we would make because we actually need to see that as part of the whole. Does that make sense?
I think it's a new process, so we have to go with the flow. And I totally agree. We're only limited in the recommendations we can make at present until we've had more data. We've had the front door report, and then we can perhaps have a better rationale on how things are progressing. Okay.
Thank you, members.
Can I ask, do you think it'd be a recommendation to ask, with their consultation, what could be the outcome regarding their staff? Because that would be leading on from this as part of the service.
Will you be able to give us that data?
I was going to say, I'm not sure that consultation from staff feedback would be possible. Rather than make that as a recommendation, perhaps I'll speak to officers outside of the...
I'm just thinking they did say it, but how we can approach it, you know?
Yeah.
So.
Bex will make inquiries on that, Steve. Is that okay? Linda, do you have any comments to make?
No, I think I just agree with the fact that this was an introduction to the process. When we see that report in January on the front door, we'll probably be able to make more constructive recommendation then. And the fact that we need the continual assessment to be done within this process, so that those areas that we picked up during the conversations and the questioning about blockages, any sort of change of direction, that there's a reassurance that will be met through continual assessment.
Catherine, do you have any comments to bring in?
Thank you, Jana. No additional ones, but I totally agree with what Linda said actually about that. I think ongoing data to bring to the committee is paramount to see if this is as effective as I think it will be. Yeah. But I think that data is hugely important for us as a committee. But it was a really good committee meeting today. Thank you.
Okay. Thanks. Dave.
I think I'd only add to Jane's point, which is actually, if we actually say, we would see the value of case studies, they can be considering perhaps starting to collect those. It's a sort of, you need consent from people and things like that. So I think it would be worth making that point. We would see this as being very valuable in seeing some of the outcomes, and perhaps consideration can be given to how they might do that and involve service users in that. Yeah.
We all satisfied? Can we move on? Yeah. All right. We come to agenda item 6, which is consideration of items for our next meeting. So what have we got left in our basket?
Thank you, members. So obviously, as discussed throughout this meeting, you agreed at Visioning to take access to the front door of social care as your item for the January meeting. In terms of other feeders that feed into your review of what item to take next, there were 2 items that are on the Exec 4 plan, which is the Community Wellbeing Strategy, but you've already taken that quite considerably before it's now going to Council. And then Contract Award, which is not suitable for a scrutiny item, and then there were no referrals from audit. So, based on discussions today, obviously I garner that you are still very keen on taking that front door to adult service care. It's obviously very, almost a 2-part scrutiny activity really today, and then general session. So,
okay, we're happy with front door. Okay, thank you. The date of our next meeting,
as long as it's not locked.
Pardon, Steve? Go on. Believe it or not, our next meeting is the 18th of January 2024 at 10 a.m. I know we can't believe that Christmas is around the corner, as they say. So, unless anybody else has to make any contributions, can I thank you all for attending the meeting this morning? I think it was a very, very good scrutiny meeting. I think we had a lot of our questions answered, and we'll probably come up with more for the next meeting as well. So, thank you all very much. Go and enjoy your rest of your day.
Thank you,
Bye.
Chair. Thank you, Chair, for